دكتور أحمد.
مساء الخير. Good evening. We'll start this webinar on the complex primary total hip replacement challenges and solutions. Before we start, I need to thank Abroad Company for supporting this webinar, and I have to thank Professor Ayman Abid for taking responsibility for this seminar, and I need to thank all the scientific committee. The program will be condensed. We'll have 3 lectures. The first one will be presented by Mr. Halawa about the total hip replacement post-acetabular fractures, and then Professor Ibrahim Al-Ganzouri, total hip replacement in acetabular dysplasia, classifications and the techniques. The third, the dysplastic hip femoral side difficulties by Professor Ayman Abid. Then there will be a discussion, and then case presentations. We'll have 5 case presentations presented by Professor Hazem Abdulazim, Professor Ayman Abid, Professor and Professor
دولة المودريتورز.
Sorry.
دولة المودريتورز.
Sorry. By Professor Yadab, Professor Samah Marai, Professor Mahmoud Abdel Karim, and Professor or Dr. Ahmed Abid, and myself.
Now we will start the scientific part of the of this webinar, and I'm at the beginning. I would like to welcome all the faculty members and attendees, moderators. The value that you are adding to this meeting is very high. We'll start the webinar by Mr. Halawa, who is going to talk about total hip arthroplasty following acetabular fracture. Mr. Halawa.
Thank you, Ayman. Does everyone hears me or not?
Yes.
Yes, thank you.
Can you start sharing your screen now?
Yes, okay.
Yeah.
You see?
Full presentation mode.
Full presentation.
رايت شو دكتور ماهر بيه زي
ايوه الايكون بتاع الباوربوينت مش شايفه انا.
اوكي.
طيب. يس وبعدين
The presentation is open in the background.
is open. Share. This is not full screen.
يمكن حضرتك عاملها presenter view. هل حضرتك عاملها presenter view ولا لا؟
I can't see the small icons at the bottom of the PowerPoint presentation. This is my difficulty. Okay. Right. The hip arthroplasty after acetabular fracture, it can be either primary at the time of the injury, and I'm going to give examples of that. It could be early within 3 weeks after trauma, and this was due to a high degree of primary articular injury to the surface of the acetabulum. Or it could be a comminution of the posterior wall that cannot be reconstructed. And again, it could be due to impaction of the dome and the femoral head. Associated head and neck fracture can be an indication for early total hip replacement. It could be in old age when there is osteoporosis and one can't achieve a satisfactory reduction and maintenance of the reduced position. I spoke about the primary situation, i.e. within the first 3 weeks. The delayed one is after 4 weeks after trauma. This can be a neglected acetabular fracture or post-open reduction and internal fixation. In that I mean after inadequate open reduction internal fixation, or there is complication from the open reduction of the internal fixation by avascular necrosis, osteoarthritis, or infection. The primary total hip replacement and acetabular reconstruction, we can fix the columns, and in my experience, there is no need, if you are going to do a hip replacement, to achieve anatomical reduction. Bridging the wall of the defect by buttress plate, mesh, or a buttress augment. Impaction graft, and then cemented all poly cups. Of course, the material of the cup has changed in recent years, and I'm speaking in this presentation in the late 80s and the early 90s. Or you can use a bulk graft with a cementless cup. However, this was not my preference at that situation. Now, in this case, you can see there is associated transverse and a posterior wall fracture. When you look at the AP of view of the pelvis, you find an end-on fracture of the neck of the left femur. And when I have seen that in the ward, I told my consultant colleague, this head is out of the acetabulum. A CT has confirmed my assessment. The head was out and the posterior wall was quite deficient. And you can see the transcervical fracture of the neck of the femur. So this is an associated transverse fracture of the acetabulum with posterior wall fracture. Now, the steps is to fix that fracture. And as I say, not necessarily to achieve anatomical reduction. And then you reconstruct the posterior wall, and then you do an autograft of the acetabulum. Then cement all poly cup into the floor of the acetabulum, and in my experience, I do all cemented, but in this case, I use uncemented stem. Now, I used an iliopubic screw fixation for the anterior column, and I used a buttress plate to bridge the defect in the posterior wall, and then I sliced the head and I did an impaction graft. And if you can see, there is a gap between the plate and the floor of the acetabulum. I bridged this with a slice of the head, one piece, and this will allow me to have a contained cavity for the acetabulum to allow me to do an impaction graft. Then I did a Zweimüller stem with a 28 millimeter cup over a highly cross-linked polyethylene cup. And this is the lateral view. Now again, this is very rarely is done a bulk graft with cementless fixation. So I took the head fixed to the roof of the acetabulum at the posterior wall, and then put a cementless cup, as you can see here, and then a cementless stem 2. This is a famous case, and my colleague and friend Ahmad Hassan will remember this very well. This case was done in 1989, in August 1989. That man was a teacher coming back from Saudi Arabia, and his car turned over in Tabuk. He was lifted by a car, cross the borders, arrived to Alexandria, and I arrived to Alexandria to find this man for 3 months lying in a bed with an associated transverse posterior wall fracture, and there is some damage to the head too. All that features with 3-month delay in the reduction indicates that he should have a hip replacement. So what we did, we bridged the posterior column fracture, and we supported the superior part of the acetabulum with a buttress plate, and we did an impaction grafting with a cemented extra cup. He did very well to start with, and this is the picture at 1 year from the operation when I came next year to see him, and you can see how the fracture has healed very well, and this is the lateral projection. I must say here, you can see at that time we used the metal-backed cup from the Haumedica at that time. Now, after about over 10 years, this case presented to me with extensive metallosis and loosening. Why? Because in our society, when they have minimal symptoms, they can carry on and take some anti-inflammatory drugs without seeking any opinion. And he didn't come back till everything was loose. I have to revise the cup and the stem. The cup was revised well, but the stem, I haven't got enough bone graft. And again, my colleague, Ahmad Hassan, who completed the job by doing a revision of the femoral component. So the principle of hip replacement here, internal fixation of the column if they are still ununited, and bridging and support the acetabular wall defect, and the autograft of the acetabular wall defect with or without extra allograft. Then cemented total hip arthroplasty, and I'm speaking about these times in the late 80s. Few cases uncemented hips we have done. This is recently and not at these days. Again, this is an associated transverse and posterior wall fracture was left. This has happened, as you can see, in 1987 in November, and it's just waited till December 1988. And you can see that the acetabular fracture has healed in a deformed position with a defect in the posterior wall. And this was dealt with by a bridging plate to bridge the posterior wall defect. And the head was sliced and impaction grafting. And that was 6 months after the first procedure. This X-ray at the bottom right is in June 1989. This hip replacement had took her for the rest of her life, and the mother of one of my colleagues in Cairo University. Again, this is this is a bit later in 2003, a neglected fracture with a posterior wall defect. At that time, we used to do, until now, we used to do the mesh and the impaction grafting. Now this is total hip replacement after inadequate open reduction. You can see in this is associated common fracture with a medial displacement of the head and associated pelvic fractures, which has been dealt with this type of a screw. This man came from Beirut with a friend of mine, and we have done impaction grafting for this acetabular fracture, which has been all united. But his problem that this screw in the sacroiliac joint has touched the first sacral nerve and caused him a lot of problem, not a lot of problem, weakness on his right foot. And this is the picture after impaction grafting here, and a cemented whole polycup with extra stem. This case is an associated transverse fracture which has been dealt with that type of plate. And we didn't undo the acetabular fracture. We have accepted that it is united, and we filled the defect, bridged the defect with plates both posteriorly and superiorly in a buttress plate with impaction grafting and a cemented cemented extra replacement. Now, the principle of reconstruction support and bridge acetabular wall defect. Again, it's not advisable to remove the internal fixation. I must say that removal of the internal fixation is rather hazardous and can be associated with a sciatic nerve injury. Autograft of the defects from the ipsilateral head with or without an allograft, and then cement total hip arthroplasty. Now, the bridging plate and mesh with impaction grafting, in that case, we didn't achieve the reduction. As I said, there is no need to do a full reduction here if you are intended to do a cemented total hip arthroplasty. Now, the difficulties after previous open reduction internal fixation, there is a high incidence of infection and a higher incidence of sciatic nerve injury. And it can result in more stiffness, and this is because of the abductor weakness and the ectopic new bone formation. It's very, very difficult to remove the old metal hardware in case of the implanted hip. And I remember hearing one of my German colleagues when he was asked about screws producing in the way of preparing the acetabulum. He says, I use the acetabular grater and then I will throw it at the end of the procedure. This means he will destroy the instrument before cementing the cup in the acetabulum. I think these cases can be, this sort of diagram is an old one, and it just gives you an idea, the number at that stage of the primary, the early primary, the delayed primary, the inadequate open reduction internal fixation, and the complication of the open reduction internal fixation. I think I should stop here now and allow my colleagues to share their experience in that field. Hello?
Mr. Halawa, thank you very much for the very nice presentation. You have presented very difficult cases. And obviously, I'm sure that there is quite a lot of discussion around the
hip arthroplasty, in cases of acetabular fracture. We'll leave the discussion till the end of the session, and we'll move to the next talk by Professor Ibrahim Al-Ganzouri. He's going to talk to us about the dysplastic hip. We'll present the classification and the acetabular defects, acetabular difficulties, and how to solve them. Dr. Ibrahim Basha, are you with us?
Yes, I'm ready, sir.
Please. Thank you.
Good afternoon, everyone. 1 second. Stop. Okay. Good afternoon, everyone. Of course, I have to thank Abbott again for giving us usually a good opportunity to support our activities at Egyptian Hip and Pelvis Society. In doing total hips in patients with the dysplastic acetabulum or hip in general, we should expect that we'll be faced with acetabular problems, femoral problems, soft tissue problems, and any problems related to previous treatment, such as femoral osteotomies, acetabular osteotomies, retained hardware. On the acetabular side, there is usually segmental deficiencies, and these deficiencies might be superior, anterior, or posterior deficiency. The version of the acetabulum is usually altered, usually in the form of increased anteversion. The depth of the acetabulum is usually shallow, and the thickness of the medial wall is quite important because that thickness is where we aim to create a new acetabulum. And actually, there was an interesting paper or study that was done back in 2009 where they studied or measured the thickness of the medial wall using CT scan in different grades of hip dysplasia, and they found that in CRO type 1, the thickness of the medial wall was around 3.8 millimeter, while in type 2 and type 3 it was around 7.1 millimeter. And actually, this is greatly in our favor because the thicker the medial wall, the more chance we have to create, to create a new acetabulum without use of bone grafts. The opening of the acetabulum is quite important to consider, and actually that's the distance between the anterior and the posterior wall, because that distance will dictate the maximum size of implant we can use, the maximum size of cup we can use. Otherwise, if we go to a larger size, we'll probably overream the anterior or the posterior column or wall. Also, we should anticipate that we might find different types of osteophytes within the true or false acetabulum. There's also a full spectrum of femoral deformities that will be addressed by Dr. Ayman later on, in addition to a soft tissue problem such as distorted location of the femoral sciatic nerve, contracting that shorter muscles, particularly the long muscles that cross the hip and knee, the hamstrings and quadriceps, in addition to hypoplasia of the ilium and significant leg length inequality in unilateral cases. We have two main classifications, the most famous, the CRO classification, and the easiest one, which is the heart of Achilles. The CRO classification is based on three anatomical landmarks. The first of which is the height of the pelvis from the highest part of the iliac crest to the lowest part of the ischium, the medial head-neck junction, and the inter-teardrop line. These measurements are made on AP radiograph of the pelvis, where we measure the distance from the reference line or the inter-teardrop line to the medial head-neck junction, and this measurement or distance is related to the whole height of the pelvis. So CRO describes 4 grades of hip dysplasia, starting with CRO 1 with less than 50% dislocation, CRO 2 with 50 to 75% dislocation, 3 with 75 to 100 dislocation, 100%, and CRO 4 with more than 100% dislocation. On the other hand, heart of Achilles classified it into 3 types, where type 1, which they term dysplasia, in which the femoral head, despite some degree of subluxation, is still contained within the original acetabulum, as we see here on the right side. Type 2, which is low dislocation, in which the femoral head articulates with the false acetabulum that partially cover the true acetabulum, hence the name 2 overlapping acetabular. As we see here on the left side, that's the true acetabulum and that's the false acetabulum. And type 3, which is high dislocation, in which the femoral head has migrated superiorly and posteriorly, as we see here on the right side, that's the false acetabulum and that's the true acetabulum. In our planning, we should plan where are we going to put our femoral or acetabular cup or acetabular component, and how are we going to obtain our coverage. Also you have to plan for our femoral component and subsequently the soft tissue management and leg length equalization. We have different options for acetabular reconstruction, starting with high hip center or placement of the cup within the true acetabular region with the use of structured auto or allograft or morselized grafts, or even with the use of vascularized iliac crest grafts. If you have a bigger defect, we can use reinforcement rings or cage with or without hook in combination with grafting, or we can use the more the newer implants such as the trabecular metal augments or custom-made implants or the long-shaped cementless implants. And the final option we have is the use of coutiloplasty or the controlled medialization of the cup with its different types. The first one that was originally described by Dunn, in which he used osteotome or chisel to break intentionally the medial wall and then grafting and use of cemented cup. That was later on modified by Hart-Vlachidis with the use of a small reamer to ream through the medial wall, again with the use of porcelainized graft and a cemented cup. And finally, Dor used also the reamer to break the medial wall, but he used a cementless cup and without bone grafts. If we look at the literature, actually we'll find a very wide spectrum of outcomes. Regarding the high hip center, that paper was published back in 2004 by William Harris, where they stated that the goal usually is to place the cup within the true acetabular region. However, in certain cases with severe bone stock deficiency and distorted acetabular anatomy, we might resort to different scenarios such as high hip center. And they stated that although biomechanical studies have shown that superior lateral placement of the hip center may lead to increased moments and forces across the hip, leading to potentially higher rates of loosening. However, superior only displacement of the hip center does not seem to adversely affect the forces about the hip. And they stated that high hip center may facilitate contact between host bone and acetabular implant, thereby reducing the need of bone grafting and increasing the chances for stable bony engraft. So with proper patient selection and meticulous surgical technique, high hip center can be a useful technique for reconstruction of elevation acetabular. Also, if we look at the literature, we'll find actually there's a lot of articles with good outcome for use of high hip center, particularly if there's only superior displacement without lateral displacement. On the other hand, there are also numerous papers stating that placement of the cup outside the true acetabular region might increase the incidence of loosening and failure. This paper from the Mayo Clinic, they stated that by placing a cup outside the true acetabular region, we double our chances of losing and failure of the cup and the stem. Also, another paper from the Mayo Clinic stated that cups that were more than 15 millimeters superior to the true acetabular region without lateral displacement were associated with increased rate of loosening of the femoral as well as of the acetabular components. Also, another paper from the Mayo Clinic, they stated that it is desirable to reconstruct the socket at or near the normal anatomic acetabular location. And I added this statement whenever possible, because in certain scenarios, it might be quite advisable or quite easier to place the cup within the high hip center, particularly if it's 1 or 1.5 centimeter above that without lateral displacement. If we look at the literature regarding the use of bud grafts, in such cases, we find that we can achieve very good results as long as the coverage of the cementless cup by the graft does not exceed 50%. And I think 50% is a bit too much. And I think we should aim usually to range between 20 to 40% coverage of the cup. Again, we find very good outcomes with the use of different types of coutiloplasty in the literature, whether you're using a reamer, an osteotome, graft without graft, cemented or cementless cups. 7 years ago or 8 years ago, we published our results using different techniques of acetabular reconstruction and subtrochanteric shortening of cerebrum, very good outcome. These are some of the cases. This is a very interesting case. This is a female patient, 58 years old, who have had a supracondylar fracture that was treated elsewhere. It united in some degree of flexion and valgus deformity. However, when the patient started to repair, she felt that her limb was getting short and unstable. We had an X-ray done for the pelvis, and that was the case. Probably that patient was walking on that articulation, but due to the valgus forces, due to the valgus malunion, that disrupted this articulation, and the patient was not able to wear anymore. So we decided to go for a total hip replacement, and we decided to place the cup within the true acetabular region. However, in doing so, we should be ready to improve the coverage because the acetabulum is quite efficient. And also, we should manage the lengthening that will happen by bringing the head down to the true acetabular region. And that was achieved by using a cementless cup in addition to a trabecular metal augment that was placed in a flying buttress position. And instead of doing a subtrochanteric shortening osteotomy, we went for a supracondylar corrective and shortening osteotomy at the same time. Another patient, heart flacitis type 2, as you can see here, that's the true acetabulum, and that's the false acetabulum, two overlapping acetabular. And again, we placed the cup within the true acetabular region, maybe with a little of medialization, and we used graft from the head as structural coverage. And here, as you can see, it's covering less than 30% of the cup with good survival 5 years after the operation. Another male patient, 46 years old, heart flacitis type 3 on both sides. He had a cemented total hip replacement 4 years ago that was placed at the high hip center. The patient was complaining of pain on both sides, but the pain was more on the unoperated sides, and we decided to start with the unoperated side, and that's the high hip center and the true acetabular region, and that's the distance the head has to travel in order to be placed within the true acetabular region, and for that, of course, we have to do some kind of shortening. We usually have axial CT cuts, narrow cuts, to look at all aspects of the acetabulum, deficient posterior wall, relative average medial wall thickness, and that's an intraoperative picture. That's the false acetabulum, and that's the true acetabulum. And we managed to place a small 40 millimeter cup without the use of cotiloplasty or bulk graft, and with the subtrochanteric shortening osteotomy, and the same was repeated on the other side, the same scenario exactly. Finally, another female patient, heart flacitis type 3, with deficient acetabulum, same technique, autograft to improve the coverage, covering around 30% of the cup again, subtrochanteric shortening osteotomy. What's interesting in that patient is that a year and a half later, she complained of pain, and there was a septic loosening of the cup, and it was changed to trabecular metal cup. What's interesting really is that during the operation, we found complete consolidation of the graft to an extent that we removed the screw. And actually, this might prove the benefit of adding some autografts to improve the coverage for future revision. So finally, by doing these cases or doing total hip replacement in such patients, we should almost always start by deciding, are we going to place the cup at the high hip center or the true acetabular region? And if we're placing the cup within the true acetabular region, we should achieve at least 80% coverage. And for that, we can use trabecular metal augments or bone graft, whether morcellized or autograft or structural graft, auto or allograft, or cotiloplasty. We should be ready by small size cup, usually starting from 38 to 42. And in doing so, we should expect that we'll be using thin polyethylene. So maybe we can use ceramic if available, or higher crossing polyethylene, and make sure that we have a 22 millimeter head ready. Also, our plan should be inclusive of the femoral management, soft tissue, and leg length equalization. To sum up, these are the options we have on the acetabular side: placement at the high hip center, use of some kind of graft, whether auto or allografts, cotiloplasty, or use rings or augments. What's really important is that always remember that acetabular component position will determine the axial position of the hip, and hence the type of the femoral prosthesis needed to restore leg length and offsets. So in conclusion, high hip center might be a good option in bilateral cases, of course not in a unilateral patient who will have a marked leg length discrepancy. And I think it's not advisable to use it in a very young patient, because I don't think the longevity of high hip center would be equivalent to that of placement of the cup within the true acetabular region. Structural graft might be a good idea whenever we feel that we do not need a graft. That is, if we have 20 to 40% of the cup uncovered. At that situation, it might be advisable to add the graft for future revision. Trabecular metal augments should be reserved if you have large part of the cup uncovered with excellent results. However, we should almost always consider the high cost of such implants. And finally, cotiloplasty is usually yielding good results, whatever the type of cotiloplasty, as long as we're not doing medialization more than 50%. Thank you very much.
Thank you.
Thank you, Professor. Thank you very much, Professor Ibrahim, for your excellent presentation, illustrated presentation on the acetabular side. And now we move to the femoral side, where Professor Ayman Abid is going to speak about the dysplastic hip femoral side difficulties. Dr. Ayman.
Dr. Ahmed, thank you very much. It's a real pleasure to be with you this evening. As being covered by my friend and colleague, Dr. Ibrahim Al-Ganzouri, given us a very good resume of what's happening on the acetabular side and how to manage the acetabular defects. Obviously, the problem is not only on the acetabular side, but there are quite a lot of difficulties that can be faced on the femoral side. And therefore, in the coming 10 minutes or so, I'm going to cover the common femoral deformities that we see in dysplastic hips, the sequence of soft tissue releases and the limitations that we find, and the debates around how much soft tissue release and how much we gain from soft tissue release. We'll then look at the aims of the reconstruction itself and how to restore the biomechanics. And possibility of using osteotomies, the types of osteotomies and techniques. We'll perhaps touch on the approaches. We'll talk a bit about the subtrochanteric osteotomy as an option. And finally, I'll finish with the distal femoral osteotomy, the advantages and disadvantages. The challenge on the for the dysplastic hip that we see is that there is proximal migration of the head of the femur. And one of the aims, as we know, is to bring the center of rotation down into the true floor of the acetabulum. So we have to overcome the problem of the proximal migration and the leg length discrepancy. We know that there are rotational deformities in the proximal part of the femur in cases of dysplasia. And it has been noted previously that there is increased femoral neck anteversion in types 2 and 3 in particular. There is a valgus angle for the neck in the majority of cases, and in many occasions, there is a posterior placement of the greater trochanter, which would hinder the abductor mechanism function and reduce the lever arm for the abductor muscles. We know in many occasions that we, in addition to the deformities, the rotational deformities, that there is a narrow medullary canal. Many of these patients are presenting in engaged, and they have very strong cortex and narrow medullary canal as part of the problem that we have to think of preoperatively and plan on how to overcome it. As been presented and shown, many of the cases of developmental dysplasia or congenital dislocation of the hip have the problem of a valgus knee and become aggravated when you have corrected the hip deformity. And we have to keep in mind that many of these cases might have received the previous surgical intervention to correct the problem of the dysplasia in form of proximal femoral osteotomies. And therefore, you may be faced with the presence of metal work that is left behind on the proximal femur. You have to think of how to remove them because it might represent a very difficult issue to solve intraoperatively. The aim from the reconstruction that we perform in cases of hip dysplasia is to try to restore the biomechanics, the abductor function. And if you look at the preoperative X-ray and the plan for it, you find yourself that, as I said, you need to correct the presence of a leg length discrepancy, but you need also to restore the offset of the abductor mechanism and to avoid complications. And we know that if we stretch too much while trying to bring the center of rotation down, bring the femur down to correct this leg length discrepancy, we are faced by the problem that there are limits for the soft tissue release, and there are limits for the tension that we can place on the femoral as well as the sciatic nerves. Therefore, it is very important to think of the correction. And before the preoperative X-ray that you see on the left-hand side and the postoperative X-ray with bringing the hip offset to be similar to the other side, center of rotation of the hip down to the true floor of the acetabulum. Between this and that X-ray, the postoperative X-ray, I mean, there is quite a lot of technical steps that we consider in terms of correcting the soft tissue balance, as well as restoring the offset of the femoral neck and restoring the lever arm to the abductor mechanism of the hip joint. There is always a debate, and I'm raising questions more than answering these questions. Actually, when I look at the overlap between the true and the apparent leg length discrepancy, we see patients when we measure the actual true leg length discrepancy, we find it 3-4 centimeters. But when we look at the apparent leg length discrepancy, we find it much more higher. And this is obviously related to the obliquity being placed on the pelvis as a whole and the soft tissue tightness. And there is no clear measure of how to assess the degree of soft tissue tightness preoperatively. All we can do preoperatively is to look at the leg length discrepancy. But we don't know whether how much tightness and the magnitude of the distal displacement that we can perform by performing just soft tissue release. How much we can limit the acute correction as well, because it is always said, and it is a quote from one of the publications, that you can only stretch to 4 centimeters or 5 centimeters. But this is obviously a very rough measure, because the size of the patient itself is different from one to another, and the pathway of the sciatic nerve is different from one to another. So we wouldn't be able preoperatively to tell for sure that we would be able to bring this greater trochanter down to the level that we wish to achieve by just the soft tissue release. We don't know how much soft tissue is going to give us. And as I said in the previous slide, when you look at the preoperative X-ray, the actual true leg length discrepancy is a small amount, perhaps 3 or 4 centimeters. But intraoperatively, this is not giving you enough indication or an absolute indication that you may not need to perform a shortening osteotomy to achieve balance for the soft tissue postoperatively and to restore the hip offset. There are different strategies, obviously, to correct the proximal migration of the femur. And one of the strategies is to perform preoperative destruction. Another strategy is to perform the transtrochanteric approach. And the transtrochanteric approach would allow you to have the abductor mechanism detached from the femur, gives you an excellent approach to the femoral and the acetabular side. And if a femoral shortening is going to be performed, it can be performed at the level of the lesser trochanter or the trochanteric area rather than going into a subtrochanteric area. Obviously, this is sometimes faced with the fact that trochanteric non-union might happen as a result of detachment of the greater trochanter. And we know that the trochanteric or transtrochanteric approach has been popularized by Chalmers in the early 70s, but it's being used by some surgeons in cases of DDH nowadays. There is obviously the strategy of performing the distal femoral osteotomy. As I said, soft tissue release, how much soft tissue release is enough or how much is adequate to bring the center of rotation down and bring the femur down? Perhaps it is essential in these cases to perform a circumferential capsulotomy. This is the first step. gluteus maximus deep insertion can be released, which is another important step. Many of these cases need to have the adductor tenotomy, whether it's usually performed as a percutaneous tenotomy. In the majority of cases, iliopsoas release is performed in many occasions, and the sliding of the gluteus medius and minimus of the iliac wing is another soft tissue release procedure that would allow bringing the greater trochanter down to the level that you would wish to achieve. This soft tissue release, as I said, and the lengthening being achieved may not be adequate to create a balanced hip with a good soft tissue balance, because in many occasions you are faced with the fact that having performed these releases, you still have a very tight hip, or you cannot even reduce the hip back into position when the center of rotation of the acetabulum is restored to the anatomic center of rotation. And that's why the role of osteotomy came into place. And the subtrochanteric osteotomy has been proposed by many authors. There is a wide experience around the literature with the subtrochanteric osteotomy, 10 centimeters from the greater trochanter, and performing the osteotomy and the shortening that is needed to relax the soft tissue and allow reduction of the hip and balancing of the soft tissue with offloading this soft tissue tightness by taking part of the metaphyseal, diaphyseal junction out. It can be around a centimeter or more, depending on how high is the dislocation preoperatively. I'm going to go into some details of the subtrochanteric osteotomy through a case scenario I'm presenting in this case, and you see that what appears to us with the preoperative leg length measurement, that this lady had around 7-8 centimeters of shortening. When you measure this on the X-ray, you may not find an 8 centimeter of shortening, but at least what we see as a combination between true and upfront shortening in this left leg is around 8 centimeters or so. And in this case, perhaps it's better to be prepared with performing a subtrochanteric osteotomy. The steps is to establish the center of rotation of the hip first. So restore the center of rotation of the hip by performing the acetabulum first. Start reaming the femoral canal and make sure that you can ream it adequately, because in many occasions we have a very narrow medullary canal that needs manual reaming and perhaps power reaming of the diaphyses before you can insert your broaches into the proximal femur. Broach the proximal femur and see how much you need to bring your femur down when the broach is in, and perhaps to start first by performing the subtrochanteric osteotomy while the broach is in. And once you have completed your osteotomy, insert the broach in first, make a trial reduction of the hip of the proximal part while the broach is connected to the proximal part of the femur, and see the overlap that is being created between the shaft and the proximal part of the femur to see or judge how much of the bone you need to take out to balance your soft tissue. We usually err towards having a smaller part removed at the beginning, and obviously you can increase this removed part as the soft tissue balancing needs to be balanced with removing parts more of the femur. The fixation of the osteotomy starts while the broach is already holding proximal to distal fragments, inserting the plate outside with unicortical screws, at least a provisional fixation, and then you remove the broach and insert the actual stem and complete the fixation of the site of the osteotomy. So it is a provisional fixation while the broach is in, and then you remove the broach out and insert the definitive stem into the proximal and distal parts of the femur and complete the fixation. If you need to add circular wires or bands around the proximal femur or the distal femur to improve your fixation, you can do so. In many occasions, some surgeons prefer to have a straight stem into the, in these cases of dysplasia, because when you have a straight stem, you can alter the rotation of the greater trochanter. You can bring it a little bit forward, and the straight stem wouldn't jeopardize your rotation, or wouldn't affect rotating the distal or proximal parts of the femur to achieve the combined anteversion that would give you the stability that you would wish to have into your implants. This is not a case of DDH, it's a neglected varus, congenital coxavara. But again, this is a proximal migration that is quite similar to Crow type 4. And you see that there are deformities into the proximal femur, narrowing of the medullary canal, and to define the true medullary canal and to ream this medullary canal to achieve good fixation of a cemental system is something that you have to plan preoperatively. And as I said, you have to be prepared with performing the subtrochanteric osteotomy to achieve the soft tissue balance that you wish to have, and restore the having restored the center of rotation of the hip, and giving the abductor mechanism the necessary lever arm to restore the function and allow the hip to be balanced as well. So this is post-operatively, and you see that how much migration had happened to the greater trochanter from being attached to the iliac wing down, but this wouldn't have been achieved without performing the subtrochanteric osteotomy. One of the techniques of the subtrochanteric osteotomy is to slice the fragment that you have removed and use it as being used on the right side here as a graft around the osteotomy site. There is the technique of the chevron osteotomy, which is a very good technique that provides the stability of the osteotomy site, having inserted a straight cemental stem into the femur. The difficulty with the chevron stem is that it doesn't allow you to adjust rotation once you have performed the osteotomy to allow for the ends of the bone to meet each other. There is finally the technique of the distal femoral osteotomy, and perhaps it is a good idea to go away from the stem bed by performing an osteotomy distally in the supracondylar area. It allows you to correct a valgus deformity, as been shown in Professor Ganzouri's presentation. So you can perform a correction of the valgus deformity in addition to performing a hip arthroplasty and fixing the osteotomy distally away from the stem. But again, it is an extensive approach, because you're going to approach the whole of the shaft of the femur, almost the whole of it, or another incision, an extensive incision distal in addition to the proximal incision. There is a possibility, if you ignore the fact that you have to keep at least a 2 centimeter between the stem and the last screw of your plate to create a stretch riser between the end of the stem and the plate for the osteotomy, and this obviously should be avoided. But again, it's very useful technique when there is an associated valgus deformity of the knee that needs to be corrected at the same time of reconstructing the hip joint. I will stop here and send a take-home message to my colleagues listening to this talk, that there are priorities and aims for the reconstruction that can be kept in your mind while you are planning for performing a hip arthroplasty for a dysplastic case. Correcting the biomechanics of the hip and having a good offset and lever arm for the abductor mechanism is something that you have to aim for and plan for preoperatively, and you have to think of avoiding complications. There is no clear cut of when to perform a subtrochanteric osteotomy and when not. And in the majority of cases, you would be just discovering this intraoperatively, and therefore you need to be prepared for performing the subtrochanteric osteotomy if soft tissue release is not adequate. You perform the soft tissue release sequentially, and you consider the structures that we mentioned from the adductors as well as flexors and the circumferential capsulotomy that would allow you to bring the proximal femur down. If subtrochanteric osteotomy is performed, make sure that you correct the rotational deformity and have a good fixation of your stem as well as for the osteotomy that was created. And thank you very much for your attention.
Thank you very much, Professor Ayman, for your excellent presentation on the difficulties on the femoral side in dysplastic hips. Now we move to discussion of the previous three presentations by our colleagues. If someone has any questions.
There are questions, by the way. You find a question and answer box on the right side, Professor Hassan. If you open it,
yeah,
there are questions coming.
There are actually two. The first two questions, I think you answer these. How much to shorten the femur, and what about the leg length discrepancy? And the other question, how to assess good soft tissue tension intraoperative? Professor Ayman.
Well, I think I tried to cover how much to take and to shorten the femur, and I said that perhaps the broach in the proximal part of the femur, you perform the osteotomy without performing a shortening, you reduce it, and you see how much overlap. And I tend always to take less than more. So if I see an overlap of 2 centimeters, for example, I will take 1.5 and try to reduce the whole of the osteotomy and try with this level and see if this is adequate. This will take me into the second question of what's meant by good balancing of the soft tissue. Well, you need to assess the tension of the abductor mechanism and the range of movement and the stability of your hip. So you place your hip into the different degrees of adduction, internal rotation, as well as abduction, external rotation, and see whether there is the stability of your hip or not. And this will allow you to adjust the rotation as well as the soft tissue tension.
Now, let me ask, do you plan before going to theater to do subtrochanteric osteotomy, or you start by soft tissue and then you see whether you will need to take over or to do subtrochanteric osteotomy or not?
Sure, yes. Well, I start by the sequential soft tissue release and see whether this is adequate. What I need to see is I have restored the center of rotation and brought the greater trochanter down. And if the soft tissue release would allow this to happen with a good offset of the abductor mechanism, this will be well and good. If not, or if I think the greater trochanter head is too tight, or the greater trochanter is hitting and having an impingement against a bulky graft or an augment that's placed on the side of the ilium, I would then try to perform the osteotomy to bring the greater trochanter more down and have a good lever arm for the abductor mechanism.
Now, let me ask, when you prepare the femur and you plan to do subtrochanteric osteotomy, do you prepare the femur first and finish, and then you do your subtrochanteric osteotomy, or you prepare the proximal part and then do your subtrochanteric osteotomy or excision of part of the femur, and then you prepare the distal part?
It's a very good question, Professor Hassan. I prepare the femur first by reaming, because in the majority of cases, these cases have a very narrow medullary canal. So you need to perform a bit of framing, whether it is manual or even power reamer, to receive perhaps the first broach. And then when it receives the first broach and I try the second one, depending on the stability of that broach, I stop at this level and I perform the osteotomy. And I try to preserve the contact between the broach and the proximal part of the femur, overlap it, and find how much do I need to remove.
Okay. There is another question, Professor Ayman. In plate fixation for subtrochanteric screw. For subtrochanteric, does the screw interfere with the stem insertion if you use plate fixation?
While the broach is already in, having performed the osteotomy, shortened, placed the broach, connecting the proximal to distal part, I place the plate and insert a minimum of 2 screws or so to provisionally fix.
Unicortical.
Then, yes, unicortical screws, Professor Hassan, or in the distal part, posterior or anterior to the stem. When I have done so, I remove the broach, I insert the definitive stem, and then complete the fixation by going with the screws posterior or anterior to the stem, depending on the thickness of the cortex of the femur.
Ahmed, may I add something, please?
Sure. Okay.
You can do the osteotomy without putting plates. Dr. Ayman described perfectly to use a plate in addition to the stem. However, it's dependent on the type of stem you're using. If you're using a diaphyseal fitting stem, a cylindrical stem, or a modular stem, you can do the osteotomy, subtrochanteric shortening osteotomy, without adding a plate, depending on the distal fixation by the distal part of the stem. Also, it's dependent on the type of osteotomy, whether you're doing a transverse osteotomy, a Chevron osteotomy, as Dr. Ayman was saying, or oblique, or even step-cut osteotomy. This might achieve rotational stability, and as Ayman was saying, you can use the osteotomized part as graft, strut graft around the osteotomy to improve the rotation. There's also another tip that, as was described by Hartwell-Achilles, you have two types of high-riding femur. You have the one with false acetabulum, and usually here the tissues are quite rigid. They are difficult to reduce, and probably you need to do a shortening osteotomy, otherwise you might endanger the sciatic nerve. And there's another type without a false acetabulum up there, where you find the proximal femur traveling away from the acetabulum. You can see this in some of the cases. As described by Hartwell-Achilles, these type of hips, the tissues are more resilient, and you might find it quite easy, not quite easy, but easier to reduce it without doing extensive release and endangering the neurological structure. So we have two types of hips. The one with the false acetabulum, that tissues are quite rigid. You need to be very cautious. And another type with flying proximal femur away from the acetabulum. And in that scenario, usually the tissues are more resilient.
Okay, another question to Professor Ayman. Is it common to do derotation osteotomy during shortening and diversion or retroversion? How to judge?
I'll just mention something, because everyone thinks the only rotational deformity that happens is an increased anteversion of the neck. In reality, I've seen some cases of dysplastic acetabulum when there is a retroversion of the neck rather than an anteversion. So you have to assess that intraoperatively quite carefully. Obviously, the preoperative CT scan is going to give you some indication. If you are using a cementless stem that is not a straight stem, that is broad proximally and narrow distally, it means that you may need to derotate the distal part of the femur at the time of the osteotomy. Why? Because you would like to achieve a good contact between your cementless stem and the proximal part of the femur, and this may push you to put your stem in a little bit more anteverted position than what you wish to have. If this is the case, and you're using this type of stem, okay, create the stability of the stem and derotate the distal part of the femur. Again, at the end of the procedure, you have to have this combined anteversion that you would need to have to achieve the stability in different directions, as you would do with a normal hip. In some occasions, when the greater trochanter, extensive anteversion of the neck, greater trochanter is at the back, and you are using a cementless system that is broad proximally, you will need to derotate to bring the greater trochanter into play and to have a good lever arm for the abductor mechanism. Thank you.
Okay, thank you very much, Professor
Ahmed. ممكن Professor Hassan, ممكن
Yes.
can I just comment on the first presentation of acetabular fractures, total
Sure.
hips in acetabular fractures,
Prof.
please.
Yeah, Mr. Halawa, yes.
I would like to draw the attention of some points. One of them is that the decision of doing hip replacement in acetabular fracture should be taken with a great care, simply because some of these cases can be reconstructed by some kind of more experience in acetabular surgery. So long that the head is not destroyed, for sure, then certainly the option of total hip replacement is not the best option. Maybe open reduction would be better than that. Now, the hardware, the amount of hardware should be minimized as much as we can do. And this can be minimized by using a bulk graft, the femoral head graft, for example, from the same patient, or can be taken from the bone bank if necessary and needed. And its fixation should be by only screws or by screw and small low-profile plates if it is necessary, so that we minimize as much as we can the amount of metallosis which is expected after doing after applying great amount or big amount of hardware, especially if we're using stainless steel material. Now, the third point is that when we operate after the hip replacement, when we operate hip replacement after internal fixation, it's much, the results are better if we remove the plates and or the hardware. Of course, this is a personal issue. It depends on whether the surgeon wants to remove it or not, whether the removal is threatening another structures or not. But I'm just highlighting a point that certainly in the literature, the results after removing the hardware is good, especially from the longevity point of view. This is what I wanted to say as a comment on total hip replacement in acetabular fractures. Thank you very much.
Thank you, Professor Hazem. Last question before finishing this part of the webinar. It is from Dr. Jamal Abu Hilal from Gaza. To Professor Ayman and Professor Ibrahim, how much can you release a soft tissue or soft tissue balance regarding the sciatic nerve? He means before damaging the sciatic nerve. How can you make sure that the soft tissue hasn't damaged the sciatic nerve?
To Ibrahim, would you like to take this question, please?
Sure. As Dr. Ayman said before during his talk, this is quite controversial. There's no absolute number. It's stated in the literature, it's between 3 to 4 centimeters. However, there's a variability of the size of the patient. A 2-meter height patient is different from 150 centimeter patients. Also, the course of the sciatic nerve, also the longevity of the disease or the pathology. The longer the pathology, the more rigid the sciatic nerve. So I guess it's a bit variable. It's around the number of 4 centimeters, but it's not the same for every patient. You have to test the soft tissue tension. Usually, these patients are operated most commonly from the posterior approach, where you can see the sciatic nerve, you can see the tension on the sciatic nerve and the posterior structures. If you want to play safe, you can have also some kind of testing of the nerve intraoperative to be 100% sure that you're not endangering the neurological structures. However, whenever in doubt, it's safer to go for a short neurostomy rather than injuring the sciatic nerve.
Thank you.
Could I just add, sorry, Dr. Ayman? Could I just add a single word? I read before, very early on, not necessarily in the DDH, that sciatic nerve injury or stretch might still occur after lengthening of just about 1.7 centimeter. That's why I'm always scared, and I'd be very careful at just Ibrahim Ganzouri you just mentioned. Thank you very much.
Professor Ayman, do you want to add something?
Well, this is actually, it has been explained very well. Dr. Ibrahim and Mahmoud said, I think we have to be very careful of how much lengthening we do. It's very variable among patients. Consider performing the osteotomy. There is no clear guide to which patient will need an osteotomy and which one will not need. You would better be prepared that if you feel that there is too much soft tissue tension, you better perform an osteotomy. Thank you.
Thank you. Now we'll move to the...
It's you now. It's you now. Let me introduce you.
Okay, all right.
We'll move to the case presentation, and I'm sure that there are plenty of questions that will come into the chat box as we move on. We have excellent presenters and speakers. The president of the society now is Professor Ahmed Hassan, is going to start his presentation. Dr. Ahmed Bey.
Thank you very much.
Dr. Hazem Abazim, I was going to moderate this case with Professor Hassan.
Thank you very much, Professor Ayman. Actually, this is a simple case, a little bit complex. She's a 28 years old female patient, epileptic. She had fracture of the left acetabulum during an epileptic fit 2 years ago, before being seen in the clinic. And at that time, no active treatment was performed for this patient. She's a female, 28 years old, epileptic under neurological treatment. She came walking with 2 crutches, complaining as expected from groin pain. The hip was very stiff, short, and she had 45 degrees flexion deformity. And as you see here, how much damage has happened to the acetabulum and to the head of the femur, and how much migration proximal and central to the proximal part of the femur. What do you think? Can we carry on, or do you want to ask some questions about these patients?
Perhaps we can get the opinion. Dr. Hazem Bey, تفضل.
Well, I am actually looking at both hips and the pelvis. This pelvis is end on. This means that this patient has got long-term flexion deformity of the hip. And consequently, when they do the trial to make an ABV for the pelvis, it comes that the pelvis is rotated anteriorly, and this makes gives us this kind of inlet view of the pelvis. Second point is that both femoral heads are avascular. And on the left-hand side, the avascular necrosis is quite obvious, with flattening and arthritis of the hip. So this is a kind of complex situation. Both hips are 45 degrees of flexion, stiff. Both of them are arthritic. And certainly, hip replacement of both sides is necessary in this situation. About the acetabular fracture, this is the type which we get always in the osteoporotic bone patients under some kinds of treatment which induce osteoporosis, where we get fracture mainly of the quadrilateral plate together with frank central dislocation of the hip. Nevertheless, we need to have a good imaging views, CT scan, 3D reconstruction, to make a kind of classification of the fracture of the left acetabulum, and where are the defects before we plan for the hip replacement. So can we see CT scans and so forth, please?
Okay, I'll show the CT scan, but just a little comment about the right side. Maybe the view itself, but actually the right side was clinically normal. And I will show you in the post-operative X-ray that the right side was normal with no evidence of AVN.
The illusion.
So the right side was, yes, the right side was actually is good. The problem was
not arthritic.
No, not arthritic, not arthritic. I will show you in the following.
Oh, في الإكس-راي دي باين إن هو arthritic.
Yeah, I know. There are some changes here in the X-ray,
yes,
but actually it was okay, the right side. These are the CT scans of the patient, and as you see here, there is proximal migration. There is the defect of the medial wall, and other cuts, the axial cuts, show also there is a defect on the medial wall. But what was good in this patient that the anterior wall and the posterior wall were good. So we have a defect proximal, central, but actually the anterior and the posterior were good. And this is the other cuts, shows also the posterior column was good. The problem actually was in the anterior column and in the floor with proximal migration of the head of the femur. This is the CT scan cuts.
If I'm entitled to continue, I can say that this patient is lucky because the anterior column and the posterior columns are reasonably good. They can hug easily or efficiently the cup when we apply it inside. We need to lateralize the cup. We need to graft this central defect. For me, I will use the available amount of the femoral head to do this job, mercialize the graft, and maybe this will be enough to repair this acetabulum.
Okay. Now, actually, regarding the Paprosky classification, I think this was type 3A, where we have
cavitary defect.
Yes, cavitary defect and also segmental defect on the floor of the acetabulum. What I did at that time, this was 2015, I did cementless hip replacement with grafting of the acetabulum and use part of the femoral head to block the defect on the medial wall, and then grafting the acetabulum, the roof and the floor of the acetabulum, and cementless cup and cementless stem on the femoral side. And this is the lateral view showing the amount of graft which was used. This actually was 6 weeks after operation. And as you see here, the right hip actually was good in this view. And then the X-ray 3 months after operation, and some of the graft has taken. And I followed actually because this patient was in the main hospital. This is the last X-ray I got, but actually she is doing fine up till now.
Well, I guess that this is the best option. You have chosen the best option for this situation. If I'm saying what's good in this, so I would say that the use of the least amount of metalware is this was a very wise choice. Of course, it's coming from Ahmed Hassan, the most experienced surgeon, and again the use of mercialized graft, and the surgeon depended on the bone shell, which has been formed during the healing of this fracture on the medial side, or replacing the damaged quadrilateral plate of the acetabulum. So the cup, the defect was full enough by the bone graft, which I guess it was impacted quite well, and then the position of the cup, the center of rotation, is quite good, and I congratulate you for this result. I expect that this is going to have a good longevity for the acetabular component of this hip.
Can I ask a question, Professor Hassan?
Sure.
It's just for the sake of clarifying this to the attendees. You did an excellent job with the cementless cup. And we heard before Professor Halawa, Mr. Halawa was saying that he uses morselized graft and cemented cup. When do you think that you are forced to use a cemented cup? And when do you feel comfortable of using a cementless cup like what you did with an excellent result like this?
Actually, age of the patient is very important issue in such cases. This is 28 years old female patient, so I was on the side of cementless cup. The other issue is that I have a good anterior and posterior wall. Even on the roof of the acetabulum, it is good. It is more or less mainly cavitary defect, which was filled well, was very stable, morselized, impacted graft, and I felt very satisfactory impaction of the cup at the end of the operation. If the patient has many defects, very porotic bone, I'll go for cemented cup.
Thank you. Thank you very much.
Ayman, can I have a comment, please?
Okay.
Ahmed, I think to my mind, my main concern here is two things. I think it was a bit difficult to dislocate this hip or maybe take the preliminary cut. So did you use any tips? Did you take an X-ray shot, C-arm, or was it straightforward? Because if you go to the preoperative X-ray, you'll find that there's no clearance nearly between the shaft of the femur. It's as if it's an ankylosed hip. So did you do any tips for that?
Oh, thank you very much, Professor Ibrahim, for this question. Actually, I didn't mention that I couldn't dislocate the hip, and I did osteotomy of the neck of the femur in situ, and then I managed to remove the head and the neck of the femur after that. So I did osteotomy of the neck first.
I think not only that, but I think it's even doing the osteotomy first is not easy because you have absolutely no clearance. So
I go through posterior approach. So I was it was actually the neck of the femur was shown very well through the posterior approach.
Aren't you concerned, sir, of instability post-operative? This patient is epileptic. Didn't you think about using dual mobility or something like that, or the longevity was your main concern?
Dual mobility was not that popular at that time in Alexandria. The second point, she was under medical treatment, and the neurological doctor assured me that she most probably she will not going to have another epileptic fits. And as you notice, I little bit closed the cup in a trial to minimize the incidence of dislocation of the.
Excellent job, sir. Excellent job.
Excellent job, Professor Hassan. Thank you very much for this case. May I take the chance to introduce my friend and colleague, a very eminent professor from India who is joining us tonight. Professor Yadav has worked for over 20 years in the All India Institute of Medical Sciences. Has performed thousands of knees and hips. And we are delighted to have him with us during the Egyptian Pelvis and Hip Society meeting. Professor Yadav, we are waiting to hear from you.
Yeah. Thank you, Professor Ayman. I'm always happy to be with my Egyptian brother. And I always, whenever they come to my hospital, whenever I go to Cairo, I always love them and enjoy with them. So this is my pleasure to be with you. Yeah. It is not moving. It is not moving.
Okay, it's okay. You can stop sharing. Go to your presentation. Go to the first slide of your presentation. Go to the first slide of your presentation and start sharing again. When you press share screen, select your presentation. Meanwhile, I would ask my colleagues, attendees, to send their questions to the question and answer box, please.
Now it is fine, Dr. Ayman. Can you see my? Can I see my?
No, no. You have to stop sharing and share again, please.
Sorry, I will. I think. Sorry.
It's okay. It's okay. Take your time. We are with you now.
Can you see?
Yes. Yes, we can now. Just put it into a full presentation mode.
Yeah. Is it
That's
fine?
Great. Yes, fine. Go ahead.
Thank you, all my brothers. So I'm happy. Nothing. This is the patient. You can see. Can you see the X-ray? 82-year-old lady, multiple comorbidities, confined to indoor activity only. First, she sustained cervicotrochanteric fracture. Total arthroplasty done for that in 2017. Had dislocation. Then patient was put on brace. Again dislocation, open reduction, and some exchange of implant done. There is no record. While weight bearing, she sustained fracture and dislocation again. Fracture was fixed. You can see over here. Can you see this X-ray?
Yes, it's quite clear.
So it bent into the non-union. Hip reduced, once again dislocated. Now patient is bedridden and she is 82-year-old. Now what to do? Challenges are multiple, medical challenges and surgical challenges. And what are the favorable factor for us? She is low demand patient, she is elderly, and weight is less than 60 kg. She is not very heavy. So these are the favorable factor. So challenges, you can see multiple surgical challenges, dislocation over here and upper part, doubtful abductor function because of, you can see, trochanter is also partially damaged, and non-union over here, lot of metal. As professor told, use minimum metal. I also strongly believe in this philosophy. Use minimal metal in life wherever you can, whether it is trauma or arthroplasty. So severe osteoporosis, poor parameters, non-union. So my dear Professor Ayman, what to do for this patient?
First of all,
there are two options. Short surgery with minimum intervention first. Either you go do short minimum surgery, minimum intervention first, or go for aggressive surgery, remove all the component, completely put longer stem, and then do the ORIF fixation as well. So what should we do?
Shall I comment?
Yeah, sure, Professor Ayman.
Can you go back to the X-rays, please? Yes, that's great. Well, obviously, first of all, let me say that I'm glad that she was your patient, not mine, because I can only suggest while I'm sitting here. This lady, obviously, as you said, she's a low demand patient. She is very osteoporotic and has multiple difficulties. One of them is dislocation, the poor bone stock on the proximal part of the femur. And if you think that you're going to remove this stem, cement mantle, and metal work, you will end up by having just a shell of bone on the proximal part of the femur. But what's good about her is that she's 82 and she's a slim person. I think you have to, or I would think that we would better think of a full revision that includes revising the cup as well as the stem side, removing all metal work, removing the stem as well as the cement mantle. I think we would think of proximal femoral replacement with a long cemented stem that would be fixed to the distal part of the femur, and having a dual mobility or a captive articulation that would maintain the stability of this hip in the remaining part of her life, especially that she's low demand, she's going to mobilize indoors. This perhaps may be the option that I would select.
Can I have a question here, Professor?
Yeah.
I can see from the lateral projection of the femur and the knee that the knee shows some signs of osteoarthritis.
Yeah.
Right?
Knee also have osteoarthritis, so, but she is not bothered about the knee. She is bothered about she can go to toilet with the help of walker or stick. That is because she almost indoor patient, 82-year-old. So should I show what I have done?
Professor Yadav, just a question, please. Did this fracture eventually heal? Because I have quite a few comments about the fixation.
This is, I think this is in the non-union.
Yeah,
it is,
sure.
Yeah, she is not able to weight wear because of this non-union as well as dislocation. So this is frank non-union. There is a obliteration of this medullary cavity, and this is bone ends are almost closing.
Sure.
So it is frank non-union. There is a attempt to bone formation, but probably it is not. So it is non-union, it is osteoporosis, and abductors are also compromised, and there is a multiple times dislocation.
Sure.
So should I show what I have done, Professor Ayman?
Yeah, please go ahead.
So as I believe, as Professor told, use minimum implant. So principle of surgery is think simple, act simple, and use minimum implant. So what I did, because favorable factor, they were like, she's 82, osteoporotic, she just want to go toilet, nothing else she needed. So what we did, we took out stem, previous stem, and took out the cement from the upper part, whatever it was possible. Then we did cement on cement type processes and changed the cup. And here we used LCP by taking out all the plate, and whatever wire we could see, we removed all that. And PSL cup, as previous speaker shown, whenever this is a striker cup, it takes excellent fixation on periphery. So it is very good for the osteoporotic bone. It is very good in the protegious situation. Even if you hammer rigorously, it doesn't go into the pelvis because it is broader on the periphery, peripheral self-locking cup from the striker. I use that. So you can see this is post-op X-ray. Now it is uniting. You can see the signs of union over here. Within
very clear.
Within 6 months, and patient is on feet. She was on bed. She is standing in the OPD after the 6 months. Now I have done this 3 years back. She is still surviving and she is fine. So fracture united, no dislocation, cement on cement processes. As Professor Ross from Brisbane, he is strong advocate of that. I have been to his center long back, 15 years back. So I picked up from that. In these desperate situations, we can come out with good result with doing cement on cement processes.
This is obviously a very nice strategy to do the minimum. Although at the beginning I thought I would remove the proximal femur, but the results that I can see from the
that
union.
is also you, Professor Ivan. That is also option, but it is very costly thing. It is the proximal femoral replacement. Money also matters, and probably she is probably now she is almost with minimal intervention. So
go ahead,
Dr. Ayman. Thank you very much, Professor Yadav. Such a great case, and I'm really impressed with the results. Just a comment, would you rather have chosen different plate length or just for the idea of discussing with our colleagues the best method of fixation obtaining union, something like proximal plate, NCB plate, one of those, just to increase the number of screws proximally and also to keep away from screws, away from the fracture side, just to increase the working length of the plate and just to abide by the rules of Perrin strip theory, because in some other cases, this fracture might not have united. So I'm really impressed that it's united. Thank you very much for that. That's what I wanted to add. Any comments from your side?
Thank you, Mahmood. Thank you, Mahmood. Hello?
Hello? Yes, we can hear you very well.
Yeah. So we did locked compression plate almost for 8 cortex proximally, 8 cortex distally. And stem was very short. It is a is a dysplastic stem. So we could get good fixation proximally in the femur, good fixation distally in the femur. So fracture was solidly fixed. So it has united. Previously, it was not.
Well, thank you very much. This is a very, very interesting case, Professor Yadav. Thank you for presenting this, and it shows that perhaps you have played it safe with the least implants to be applied, and the patient is quite happy 3 years down the line from the surgical intervention. Thank you for this. Please stay with us. We have a couple of cases, and we may ask you to comment on one of these coming cases.
Sure. Should I go for other cases, or it is enough?
Can we still have 3 cases by other speakers?
Okay.
Can we give them a chance?
Yeah.
Professor Zamil, Fuad, you are with us?
Yes, I've been with you since the beginning and enjoying every minute of it.
Okay, well, you're moderating the next case with Samih Marai. Please.
Okay.
السلام عليكم تقريبا. ايوه يا فندم سامعني؟
Go ahead. Professor Zamil is with you now. He's moderating your case. Samih Marai.
Professor Ahmed Hassan, Professor Dr. Ayman Abeid, thank you for inviting me. This is an interesting case presentation for the use of the total hip replacement for salvage of complicated fracture femur. A long scenario starting March 2019 by this patient, 33 years old, have had a road traffic accident, and he have an isolated distal third fracture femur. All of us will say that it is a simple case for a retrograde nailing, and this was a post-operative X-ray. This was in April 2019. I would ask Dr. Fuad Zamil about his opinion in this X-ray and what complication he would expect to occur.
And what? Sorry, say again.
What do you expect the complication that will occur after this? You see this X-ray, And what's your opinion in this retrograde nail?
Okay, first to start, I'm not a great fan of retrograde nails. Personally, if I had this fracture, I would not have gone for an intramedullary fixation. I would probably have used a distal femoral locked plate. And I've probably, because of the comminution and the anterior butterfly fragment, I would probably have gone for a relative stability principle as by the AO. I would have used something with a longer length, as was mentioned by my good friend Dr. Mahmoud earlier on, and try to fix it like that. But since you've used this nail and you're asking me specifically about what complication I would expect, I would be worried about this holing that is present at the proximal end of that nail. There's definitely has been some drilling that went through for some reason. I'm not 100% sure why. You probably know better. And there's the anterior cortex on the lateral view has been breached. The posterior cortex in the lateral view doesn't seem that it has been breached, but there's also a breach of the medial and lateral cortices as well. So with such a short extension of the proximal end of the nail and the screw within it, I would have probably expected a risk of a proximal fracture, what we call a peri-implant fracture in this case. That would be my expectations.
This exactly what have happened. He created a butterfly in the distal fragment. He has a protruding nail in the knee, and he created a stress riser proximally that resulted in a fracture. By November 2019, he fixed that fracture by doing a plate over nail and removed the proximal looking screws. Also, what complications would you expect?
Right. I mean, the first thing so this happened when we didn't see actually the fracture, or did you just put the plates as a prophylaxis?
I don't know. The story that I entered again to the operation to do the plate, but
and that was how much time after the first surgery?
About 6 months.
6 months after the first surgery. So what you can definitely see is that you have a frank non-union occurring at the original fracture. Proximally, I can't see anything in particular that is worrisome to me, except that perhaps there has been a little bit of filling and union within the original cracks that were present or drills that occurred. Obviously, that knee is not in a very good state. Especially with the knee, with the nail that is a little bit protruding. I'm not sure what is going on in the knee, but you have non-union at the original fracture, and I can see that probably that would be causing some problems to the patient.
By December 2019, the patient alleged that while he is elevating his leg on the bed, he has had a fracture of the neck of the femur, and the surgeon went again to remove the proximal plate and put 3 cannulated screws in this very bad manner and left a broken screw behind from the old plate. And the patient presented to us in our arthroplasty unit, consulted by the group, by Dr. Ayman Abed and our group. He had a sinus in the mid portion of the thigh, and the plate was removed and the screws inserted in the neck. The distal fracture is still non-united, and I shocked when Dr. Ayman said that I should do this case. He is now infected. Professor Fouad, what do you think I should do?
Well, you should send it back to Ayman since he told you to do this case. But then, yes. Well, I don't. First of all, I don't see very well the hip. Do you think that this hip is damaged or not? Because I think this patient is 30-something, isn't he? He's in his early 30s, right?
33.
So the first thing I want to see if you do have better x-rays about the hip to see whether this hip is still salvageable or is this femoral head damage. This is one thing I want to have an answer to. The second thing, you're telling me he has a sinus. Where about is the sinus?
It is in the midshaft of the femur.
Right. So basically you have a sinus on a fixed femur with an intramedullary device. So to me, that intramedullary device has got to go. And you need to debride this whole femur. It needs to be washed out. My other concern I would have is that with such a situation, when you open the knee, you might convey some sepsis into the knee, so you might end up with a septic knee as well. And I would have great worries about what's going to happen to the proximal femur as well. I don't see very good X-rays, unfortunately. I can't see the views whether there's a non-union in addition to the varus, or it's just a varus with union. If it's a non-union with a varus, then you have definitely a big problem. So the rule of thumb is you need to remove the intramedullary metalwork completely. You need to wash out the medulla. You need to clear out all the infection, and then you can take it from there. If the femur, the proximal femur, is still viable and the femoral head is viable, then my future plan, until I deal with that infection, is that I need to do two things. I need to stabilize the ununited femoral fracture, probably with an external fixator after I do the debridement and the washout intramedullary. If the infection hasn't reached the proximal femur, then I would probably wait, keep the screws in if I think that they can be away from the infection site, which I doubt, but if they are, until at some point when the infection has been cleared out. If the femoral head is viable, which I can't swear about in this view, but if they are viable, then I would go in and remove these screws. I'll fix the fracture distally. I'll try to do some kind of an osteotomy to preserve the femoral head. If the femoral head is gone, then we have to have another plan, because then probably that hip will need to be replaced. But we can never do this until obviously you follow all the protocols of clearance of infection, following the ESR, CRPs, make sure that everything is cleared. You have to remove the whole metalwork before you proceed with any arthroplasty. So these are my general plans depending on the status of the hip. Do you have any better, bigger views of the hip?
I don't have any views other than these. I have collected these, but the femoral head is completely destroyed. It is a subcapital fracture which is badly fixed, presented late, about 6 months after the operation. We think hope for another fixation, so we decided for 2-stage revision.
So basically, the femoral head is destroyed, right?
Yeah.
Yeah.
Okay. So yes, that answers my two options of questions. So basically, if the femoral head is destroyed, then I would go in. I would wash out and debride the medullary canal with that nail completely. I will put some kind of an X-fix first. Go into the hip, remove the screws, and put a cement spacer, and then wait until the infection has been cleared out completely. By which time, then I would go back again to replace the hip proximally and fix that fracture by surface fixation distally. That would be my plan.
Professor Sameh. Hello.
Okay. Hello, to Mahmoud.
Hello, Professor. I totally agree with Dr. Fred. Just a small comment. I might just not to use, X-Fix is a great option, but in my hands, I might resort to some sort of intramedullary coated nail with cement contain, including antibiotics, Imralak kind of thing. If I can incorporate it into a spacer proximally by some sort of improvisation or customization, that would be great. Just to make sure that two things, that I clear the intramedullary part, and also there is local antibiotic delivery there. Also to avoid the pin tract infection, which might happen from the X-Fix in the interval between the first and second stage. That would be my suggestion. Thank you.
Okay, this is what I have done in the first stage. I decided to remove all the metal hardware. I removed the nail from the knee and remove the screws proximally, and I will do the debridement proximally. So the patient position was semi-supine, between the supine and lateral position. Started by removing the nail from the femur, and then go proximally by an extended posterior approach for the debridement and removal of the proximal screws. As you see here, the fixation is very bad. The screws have many washers. One of them have 4 washers, very weak fixation, and the femoral head is destroyed. Another intraoperative photo for the severe infection and the massive periosteal reaction that has occurred in the last operation. The protruding screws that have multiple washers. I started to do extensive debridement first for the soft tissue. And then I do dislocation of the hip, as Dr. Ayman Abed taught us that for revision of the failed fixation of the femur, we do dislocation before we remove the hardware. I remove the 3 screws with multiple washers, and you see on the right side of the picture the femoral head, which is destroyed by the multiple attempts of fixation by the screws, and how it is necrotic and subcapital fracture. Extensive debridement and reaming of the medullary canal have been done, and widening of the screw holes, removal of the broken screw by tapping on it from lateral to medial, extensive debridement of the soft tissue and of the sinus, and cultures were taken from multiple sites, from the membrane, the osseous membrane, and from the acetabulum. And I started by doing a long spacer fashioned over rod nail to reach the distal part of the femur as distal as I can, and the distal part have been reamed well. And the patient have post-operatively 6 weeks of IV antibiotics. He have Staph aureus infection, followed by 6 weeks of oral antibiotics. And this is the final post-operative X-ray. Dr. Fouad,
I take it from this that that non-union was a bit of a stable non-union. Is that true?
Yeah. Yes.
Okay, so that's an advantage that you have this unstable non-union, so you didn't need to try to stabilize it with anything. So basically, this is a very good preliminary intervention that you've made. Once the infection has been cleared out, then what I would advise you to do is to try to replace that hip, but I would probably use a standard stem, not a long stem, and I would fix that on top by surface fixation. That would be my choice. Probably, obviously, that your non-union has to be grafted as well. So my plan based on this, once you've cleared out the infection and all your inflammatory profiles has been negative, especially if you take some kind of an aspiration and it's negative, comes out negative, then you would go in and I would replace the hip. Technically, because of the non-union, I think what you wanted to ask, what you're going to be doing technically. So technically, I would fix the distal femoral fracture first with a plate that I would probably extend somehow. And I would use a long plate, a very long plate, to make sure that I'm going to bypass the extended length of my stem, because I don't like to leave any spaces between plates and stems. I wouldn't put the screws very proximally. I would just probably put 1 or 2 screws just proximal to the fracture so that I would obtain some intraoperative stability. Then I will proceed, replace the hip proximally, and then perhaps put a few screws based on the same principles of long length working of fixation on that fracture, and I will graft the fracture as well. So that would be my plan.
Okay. Dr. Mahmoud, you have any opinion?
No, I totally agree with what have been done. But the only thing which I might have done differently now with the spacer, the custom-made spacer, just to have a very good shape of the head proximally, I will start with the standard spacer and then another K-wire or shunt screw, fix both together. Now, I could have just only bypassed the other distal fracture as well, just for peace of mind. You know what I mean? So as not to work as a stress rider at the end of the spacer. But again, you could argue that you could also have used one of the very diameter 9 intramedullary nail, as I just mentioned. Thank you very much.
The only thing I would add with these spacers is that I don't like these types of single component spacers, because I believe that these sort of composers, which are more or less similar, either custom made or G-stem type, I don't like them very much because they tend to eat up the acetabulum. But in this particular case, I think you've done the very good safe thing, because I didn't expect that particular patient to walk on that custom-made prosthesis.
Yes.
So this is sort of a static spacer anyway.
Dr. Fouad, they will only eat the acetabulum if they are kept for a long time, or do you mean even in the interim, like 2 to 3 months? What do you think?
Yeah, that's. I agree with that, but you can never predict what's going to happen.
Yeah,
I've seen spacers after 2 months and 3 months perforating within the acetabulum, eating up a little bit of the bone.
Sure.
I don't think they help the patients to walk that much, and they tend to break. So the G-stem sort of spaces are not my preferable. If I want to use one of these things, then I will resort to the Prostalac type of implant. But in the past few years, I've been using static spaces just with a cement piece of ball, and I haven't found that much difficulty in obtaining the good functional range that we would expect with the Prostalac. But that's a debatable issue anyway, as you probably know, Mahmoud.
Yeah, sure. Thank you very much.
So I prepared for the second stage. The patient appears at April, and the ESR and CRB was declining, and finally he appeared this month.
So can I just make a mention, because before you change the X-ray? Thank you very much, and I'm sorry, Asama, because you see that's the picture that if this patient waited for 3 or 4 months away from you, will end up with a superolateral defect of the acetabulum. So because he didn't walk that much on it, and it's tended to sublux, and it's hinging on the superior wall, but it's good that your patient are very close to you, so they come back early. Thank you.
He come back at April, but he disappeared again, and he came at December when I did this operation this month.
Yeah.
With this problem, because of the waiting list and the issues of crowding in the university hospital. Okay, I prepared for the second stage. As usual, I will do a posterior approach. I wanted to do a dual mobility cup, but it wasn't available. And I prepared for a stem that is not long. It is shorter stem, 20 centimeter Wagner stem, and to fix the fracture by plate overlapping the stem. And this was the details of the second stage done this month. Extended posterior approach, exploring the sciatic nerve and preparing for the short external rotators, repairing and reaming of the acetabulum, and the insertion of the cemented cap and Wagner stem. It was stable, it was available at that time. And then I explored the fracture. It was an varus union, not complete union. I made an osteoclavis by the multiple drill holes in the fracture site, and I fixed it by the long DCB by passing the stem by 2 screws. This is the C-arm photos. This is the cup in a good position, the Wagner stem, and the fracture fixed by 2 screws above, by passing the stem, and 4 screws above the fracture and 4 screws below the fracture site. And this is the final postoperative X-ray. Fuad?
Well, this is very good. You did a very nice job. My only questioning is this gentleman is in his 30s, right?
Yeah.
Is there any reason why you chose a cemented cup on this particular patient?
في الحقيقة أنا ما كنتش أقدر أغير ورقه لأنه هو اتغير كذا مرة في الويتنج ليست. يعني ما قدرتش أعمل له قرار أحسن من كده بحيث إن أنا أركب cementless cup and cementless stem، فاكتفيت يعني إن أنا أحاول أعمل good cemented cup.
I think this is a very good work you've done. The one comment I would add, which I think has been mentioned earlier on by my good friend Dr. Mahmoud, is that I would probably have used more space screws around the fracture site. I would have to probably remove the most distal, the screw which is in the proximal fragment, which is basically the 5th from below. The one which is close to the fracture, I would probably have removed that to allow a little bit of more springing. And obviously I might have used a different type of plates, but you followed the excellent principles. So you fix it with a surface fixation. You probably grafted this, as you said, you did an osteoclasis and you drilled it. Yeah. And you bypassed the end of the plate, of the stem. So this is brilliant prophylactic thing to do, so that you don't have an interprosthetic or an inter-implant prosthetic fracture. And you've done an excellent job. Thank you very much.
Dr. Sabah, I have a question. Dr. Sabah, there is no clear explanation why did this patient have a fracture neck of the femur. He was fixed with plates on the nail. If you go back, with no clear fracture, as Dr. Fuad was asking, and then they removed the plate and he had a fracture on neck of the femur. And if you go to the pre-operative X-ray, I think that fracture might be a pathological fracture for a reason, because it was a simple transverse fracture like the bisphosphonate fracture. Don't you agree about that? Maybe that patient had a predisposing factor for that. Is this a common pattern to see, Fuad?
It's not a common pattern, to be honest, but to me, according to the history, this is a 33-year-old male. He hasn't had any symptoms before. Obviously, this is a fracture which is not very common, depending on the mechanism of trauma that this patient has been exposed to.
The clear-cut fracture like this one.
The clear-cut it's a bit of an odd fracture, to be honest. I would agree with you. The one thing I'm also concerned about is what has been going on with the knee, with this retrograde nail, but that's something beyond the scope of this discussion. Again, when you see this view, I don't see anything on the around the neck, on the neck that would raise my suspicion of something.
But
so,
on this X-ray, it appears that there's a shadow of stress fracture or like that.
If it was a
when reviewing this X-ray, I think
is that on the inferior neck? Is this around the sclerosis on the inferior neck?
Yeah.
Perhaps this was a stress fracture then. If that was a stress fracture, then probably it's probably a stress fracture. Yes.
Yeah.
Okay. Well done, Dr. Sama. Thank you very much.
Thank you. Thank you.
Thank you, Professor Zamil. A very structured discussion, and thank you very much, Samah, for presenting this difficult case scenario. We still have two very interesting speakers to join us, and I kept them till the end because I know that people will wait to hear Mahmoud Abdul Karim. We are looking forward to listen to your talk. And in fact, on the question and answer, there are a couple of questions that I think will suit your presentation. Mahmoud Abdul Karim.
Sure. Thank you very much, Professor Ayman. Thank you very much, Professor Ayman. Thank you very much for the kind invitation. I'm always delighted to participate in any activity belonging to the elite Egyptian Pelvis and Hip Society. Right, just because we are running out of time, I'll start my case presentation. Right, 26 years old female patient having history of DDH and then having multiple surgeries, osteotomies since she was young. Unfortunately, she had amputation of the contralateral side, which was below knee amputation with a fitted prosthesis. That made my job quite difficult because the other side is very precious. Well, all limbs are precious, but whenever you face a patient with contralateral amputation, you start to be scared from approaching this limb. She was quite disabled when she presented to me, unable to walk and using a wheelchair. Was very keen to be able to mobilize. And that was her X-ray on presentation to me. Some kind of osteotomy along with angulation in both planes, quite dysplastic acetabulum with a bit of left drill bit there. So just to complicate things, the angulation wasn't only in the coronal plane, but also in the sagittal plane. So I had both, rather complex acetabular side as well as femoral side, in addition to soft tissue complexities. This is her CT scan. Okay. And I think that's what the story, just to cut the long story short, because we are running out of time. Professor Yadav, what would you do? Could you please comment?
Can you show me the X-ray once again?
Sure.
Basically, there are many difficulties. First, in cup preparations over here, there is a cup has to be over here. There is a less bone stock. Second, femur is deformed. So it will be very difficult to pass any stem. And third, the entry of stem will also be very problematic from where to get entry. So for me, I would like to make cup over here. I may use some allograft for the preparations of cup, and I will do osteotomy at the site of angulation. And then I will do use long stem, distal fitting stem over here. I would like to take fitting over here, and like Wagner stem. And here I may use dual mobility, because here we do not know about the strength of the abductors. So and it is very challenging case, and bringing femur down will be very difficult without osteotomy. So osteotomy will serve two purposes. First, deformity correction over here, and second, it will bring down this area, this femur over here. So that will be my approach.
Yeah, sure. Thank you very much. As you've correctly said, that was her CT. Just to go through what I've done, I always plan like that. This is just for our junior colleagues. I like always to write things down so as not to forget anything. And I always plan for my patient, writing what is the intended plan, most likely plan, the instruments needed, especially in certain places in Egypt. And also on standby, I'd like to keep quite a few things I might just need. So that's my planning for the case. And as excellently explained by Professor Ayman Abeid, that's the kind of osteotomy I was looking at, except that it's more difficult because it has also associated angulation. And as you correctly said, Professor Yadav, I needed to remove a wedge rather than a transverse osteotomy as explained previously. So I like always to take intraoperative X-ray. So what I've done, because having been trained on the hands of our master, Mr. Halawa, in the southwest of UK, I was trained to prefer or to be inclined into more biological kind of fixation. So on after making the approach and doing all the soft tissue releases, as excellently explained in the previous presentations, I attempted to reconstruct the acetabulum using a mesh and a graft, and the impaction grafting technique, and also put a very small, the smallest cup was available. I wasn't able to use any tripolar because the smallest one in Egypt was at that point, I think it was 46, 48, something like that. They never had any smaller size. And also regarding your comment about the Wagner, the smallest one available is basically diameter 14, which wouldn't by any means pass through her femur. Actually, I was forced or obliged to use the smallest extra design, which is basically the CPT design, just because of the narrow medulla. Now, on the femoral side, as you could see here, what I've done, corrected the angulation both on the coronal as well as the sagittal plane, fixed that with a plate, a couple of screws there, cut screws proximally. And I prefer to use the cementless if this was feasible, which wasn't the case. But just also because the cement might go into the osteotomy side. But again, having been trained again following this school by Mr. Halawa, as I just mentioned, with proper cementing technique, with proper looking after the osteotomy and also the cementing not to go through the fracture side, well, I was lucky to go through with that. And that's how it looked on the lateral view intra-operatively. I wasn't able at that surgery because there is another surgery, which I'm going to mention in a minute. I wasn't able to remove the drill bit. And that's how the AP looked at that point. To me, it looked, the inclination angle of the cup is fairly acceptable. Anyway, just because of the time, well, 2-month follow-up, she had this because of the, I don't know, the high stresses in addition to, I tried to make a failure analysis. I wasn't able to judge. But anyway, one of my colleagues in the governor where she resides done a favor for me, and because she was in a lot of pain, he took her to theta and reduced that at that time. And the cup looked okay to me at that time. Anyway, a few days later or 2 weeks or whatever, then again came out. So I told her, you have to come to me again. And so I decided to revise her. What would you do different? Well, what would you do at this point, Professor Yadav, or your comments?
So she is a young person.
Yes, 26, 27, something like that.
So I will find out what is the cause of the dislocation.
Sure.
There has to be some cause. Probably it might be because of lack of combined antiversion or some bony impingement.
Sure.
Or probably I think the stem is quite well fixed. Stem is also not loose.
Yeah.
So most likely it is problem of abductor and combined antiversion. So it will be intraoperative decision. Intraoperatively you can make out what is wrong, why it is being dislocated again and again. So we will go with all the option and find out the basic cause, and we correct that.
Yeah,
so
sure.
Keep in mind combined antiversion and probably status of this system as well.
Sure. You're absolutely right. And before saying what happened intraoperatively, I prepared myself for a lot of revision options, including different strengths and cages, etc. But at that time, we started to have this excellent, to me, in my hands, excellent piece of device, which is basically the Delta TT revision with all its options. It's basically had a press-fit cup, 1.6 press-fit, 6 holes for screws through the cup, 3 cranial wings, as you could see here, which you could add some graft, like autologous graft or allograft, or even any kind of, they have what they call modules, which is basically like augments. You could feel free to use ceramic and suitable for primary and revision. And as I just mentioned, it accepts cranial modules like augments. And also it had, in addition to that, just inferior hook, caudal hook, just in case if you want to have more mechanical stability. But also because I thought, as you correctly mentioned, that the abductors are still under a lot of stress. It's obviously very weak and very wasted. So I need some sort of constraint, which I like to add in the previous surgery. However, I couldn't find the suitable implant, like the tripolar, the size, as I just mentioned previously. So the beauty about this piece of device, it has what we call angled spacers, which you could cover it, and they have different angles and different lengths. So you could always substitute for any deficiency. In addition, it works as a sort of constraint. And also the beauty is you still dial these spacers and rotate them about 360 degrees, as they mentioned. And again, you could add the hemispherical module, as you could see here, at the proximal part, just in case if you needed to add, if you don't have a bone stock or if you don't have autologous or allograft. That's what I used. Sorry.
Which company this cuff have? Which company?
This belongs to a company called Lima, which has an agent in Egypt.
Egypt.
Mahmoud,
yeah.
Can I ask you, Mahmoud, a question, please?
Sure.
What is the size of the cemented cup you used initially?
I think it was might have been 44, 42, something like that.
Okay, and the Lima system, what is the smallest size?
The smallest is 50. After removing, I'll show you in a minute.
Yeah,
sure. Well, I completed that by the impaction graft, but anyway, intraoperatively, I felt that the graft didn't take particularly well. So I removed everything, and I thought the stem was very well fixed, thankfully. But on the acetabular side, the cup, I wasn't quite sure whether it's really well fixed or not, because I think in some cases, I was discussing that with Mr. Halawa, that in some cases with sclerotic bone, the bone graft, the impaction bone graft might not take. But also, I have to blame myself.
If you go back with the X-rays, I think there is a loose area which goes around the cement.
That's what I thought as well. If I go back just to show you, you're absolutely right. And that's why I was keen to revise everything. But also it might be the faulty technique. I might have been not very generous with the bone graft because I had couple or one femoral head, as I'm sure sometimes you experience that as well, Professor Sadek. Sometimes when we get the femoral head, it looks very black, very odorful. So I preferred not to use it. I used just another part from only one femoral head, and I used another piece of bone from the femoral osteotomy, which might have been wrong because this part was quite sclerotic. Anyway, I have to blame my technique, but also as a take-home message, not every technique suits every single bone quality. That's my best guess again. That's how you bend the wings, and also whenever, because she had such a small acetabulum, this hook wasn't fitting very well. So it's very versatile that you could break it there, and then that's the intraoperative and how you fix it proximally and add some modules, augments, or bone graft, whatever you want. And then this part is actually two component. It doesn't show here very well. There is a spacer, which I just mentioned. It changes, it's a phase changing spacer. So it could, even if this looks quite vertical or a little bit vertical, this could compensate for that. And then again, you could add one of the polyethylene cups with elevated posterior lip, okay? And that what the final results post-operatively. And as you can see here, I was more or less able to restore the center of rotation as much as possible as I could. But again, I wasn't very worried for these few millimeters proximally because anyway, she's having amputated, the other limb is amputated. So she could adjust the prosthesis in addition, obviously, to the other biomechanical factors. I was able to put quite a few screws here. The femoral side was healed very well. And again, that's the lateral view. Okay, and that's 3-month follow-up. She was quite keen to repeat quite a few x-rays. And again, as I mentioned, she resides in one of the other governorates. So she wasn't able to attend my clinic every time. So she used to send me some x-rays. So sincere apologies for some bad quality of some x-rays. And now at 5 months, she was very keen to repeat that to avoid any dislocation. And then this is the at 7 months, and that's the lateral view. I think complete union here. I was lucky. So as because the cement didn't go into the osteotomy, I was lucky to have that. And that the lateral orientation of the cup, I think it's rather acceptable. And that's the 9 months follow-up. Now, actually, out of blue, I found her visiting me last Wednesday. I swear I never called her to come to have this video. So it's now nearly just over a year. Okay, might not play, I'm sorry. So anyway, in this video, she was just walking comfortably, and she was doing very well, and she was quite delighted with the results. So just to leave some time for my dearest colleague, Dr. Ahmed, for his great case, which is going to show in a minute. I think the take-home messages from this case, these cases are quite challenging cases. I think I would still need to go through proper detailed patient counseling, especially with such case with very precious limb, bone quality, proper bone quality assessment. And again, we need to take due care for the technique because the technique matters. It might be my fault during the first cases. Thank you very much.
Thank you, Dr. Mahmood, for excellent and very educative case presentation.
Thank you. Thank you, Mahmoud. Very interesting case scenario. And,
thank you very much.
The message was quite clear to everyone in regard to who would be the best candidate perhaps to have the induction graft. And the difficulties that could arise with the impaction graft and the mesh. But you have solved it very well with this versatile technique and modular implant that I've used. Thank you.
Thank you very much.
Very, very interesting case. Thank you very much,
Professor. Thank you.
The last but not the least, we have Ahmed Abed is presenting his case, and I think it is showing us some of the challenges and solution both on the acetabular and the femoral sides. I'm not sure if Ayman Suleiman is with us. He's supposed to be moderating this case. If not, Professor Ahmed Hassan is with us. Professor Hassan?
I am here. I'm here, Ayman.
Okay, would you moderate this, please?
It's okay. It's okay. Right.
Yes, please. Ahmed Abed.
It's my honor, sir. Good evening, everybody. I'm so delighted to be included in this distinguished panel. Thank you, Professor Ayman, for inviting me. I know Professor Abdulkarim for giving me some time to present this case. This is 45 years old. Was during the injury for fixation of a fracture acetabulum that was complicated by a vascular necrosis of the head and hardware 5 months after the initial. This is his X-ray after 2 years. He has 10 centimeters shortening of his. Actually, it isn't that extreme case. It's a difficult case with previous surgeries. I went through the literature and found this paper published this year coming from South Korea, comparing total hip arthroplasty with subtrochanteric high hip dislocation secondary to septic arthritis. They concluded that these cases have less favorable results with increased risk of complications in these cases. Professor Ahmed Hassan, this is a CT of this patient. There is no some flimsy fragments of the femoral head. CT, this is the coronal cut. It's very shallow acetabulum. And this is the 3D reconstruction of the CT of this patient. He had
Ahmed, I can't hear you. Dr. Ahmed.
Perhaps we can switch off our cameras to allow him to present. It might be better to close our cameras as well, not only his camera, for better streaming to happen.
Do you see my screen?
Yes, we can see your screen.
Okay. بس زي دكتور ايمن ما بيقول لو احنا قفلنا برضه هنقلل اللود عليه اعتقد. Thank you. Okay.
Okay. We can.
Okay.
See...
Can you hear me now?
Yes, we can.
Okay. Professor Ahmed Hassan.
Dr. Ahmed, I would like to know whether
the 3D CT.
Can you hear me, Dr. Ahmed? Dr. Ahmed.
Yes, I'm hearing you.
So this patient had 2 operations. What was the first operation? What was the second operation?
The first one was reduction internal fixation of a fracture acetabulum.
Okay. And the second operation?
For removal of the hardware.
Why? For infection or what?
A vascular necrosis of the femoral head.
But there was no infection.
It's not infected. ESR, CRP are negative, and I did aspiration before the surgery.
And do you think that the routine, if the patient has AVN of the femoral neck or the femoral head, you remove the metalwork
Of course, not
of the
there.
acetabulum?
This was the first presentation of the patient with me. He had these previous 2 operations elsewhere.
I know, but I'm asking if this is the routine we expect to treat a vascular necrosis of the femoral head in acetabular fracture by removing the metalwork?
Of course
That's
not.
why I'm asking this patient was infected or not.
No, it wasn't infected when he comes to me. It wasn't infected. The ESR and CRP were negative, and it was sealed wound.
Ahmed, might just suggest to switch to another connection, like your mobile connection? Or
I am using.
Yeah. Okay. Fine.
Now you can. Okay, I am using it now. Do you hear me now?
Now, yes, we hear you better now.
Okay. Voice is breaking, dropping.
Yeah.
Okay. Professor Ahmed Hassam.
So you have now a patient with a fractured acetabulum 2 years ago who had a vascular necrosis of the femoral head, and the problem are a high riding femoral, the head of the femur or the proximal part of the femur, and on the acetabular side, the main problem actually is the loss of the posterior column and the posterior wall of the acetabulum. So these are the 2 problems, one on the femoral side and the one on the acetabular side. And there is no evidence of infection. So we treat this patient as a clean patient, okay?
Okay.
Right.
What would you choose, sir, for the acetabular side?
For the acetabular side, I have to reconstruct the posterior wall of the acetabulum. And myself, I like to use the biological means of reconstruction of the acetabulum. So myself, if I go for this patient, I will go for allograft and use mesh to reconstruct the posterior wall of the acetabulum, and then I use cemented cup for the acetabulum. I think on the femoral side, there may not be a big problem because this patient had a normal upper end of the femur, and I think it can go down with maybe some little problem, but I think at the end I may not need shortening osteotomy. I need soft tissue, good soft tissue release. I may not need a femoral osteotomy.
Okay. This is intraoperative photo of the patient. This is the greater trochanter protruding just distal to the anterior superior iliac spine. This is intraoperative photo for the acetabular.
Can you just go back a little bit for the photo before the slide before this one?
Yes,
what's on this side? Is this?
This is an old burn. This is an old burn. An old burn. Yes, sir.
Okay. All right. Okay. It's okay.
This is I used the C-arm image before reaming my first reamer to decide where should I start reaming because the acetabular was very shallow. I recommend this step for all my junior colleagues. I start reaming and I found that it was uncovered the cup completely superiorly and posteriorly. Actually anteriorly, and medially, and there is no support superiorly and posteriorly. Professor Ganzouri covered this part so well in lecture. Actually, allograft was not available with me, so I used the largest augment I could have, putting it in a flying batteries position to support the cup superior and posterior. After doing that, I insert a dual mobility cup. I couldn't get initial fit for a cementless cup, so I used a cemented dual mobility cup. I was afraid of dislocation post-operative, so I used dual mobility cup. the same technique for osteotomy described by Professor Ayman Beid. I used a transverse subtrochanteric osteotomy. After all the releases, I couldn't do a trial reduction of the prosthesis, so I did a trochanteric osteotomy, subtrochanteric osteotomy, and fixed it with a plate, just like what Professor Ayman described. This is the trial reduction with the plate over the femur, and this is the post-operative, immediate post-operative X-ray of this patient. Any comments, Professor Ahmad?
Okay, so you tried on the femoral side to soft tissue release first, and then you use the trial.
I did all the release, and I released
okay.
The gluteus medius all through the iliac wing. I used a preosteal elevator, inserting it just inferior to the gluteus medius and it over the iliac wing, but iliopsoas release was done at ductal tenotomy, but it didn't get down more than 4 centimeters. So I had to resect 2.5 centimeters from the femur.
Right. I think on the acetabular, Sam, if I'm not sure whether this cup a little bit closed or not. It's there is some little bit high center of rotation,
of
but
course,
if the cup is closed, or this is because you use the dual mobility.
This is the version coming from Zimmer. It has a posterior flange, and because like the 10 degrees of the all poly cup, and because of it's made of metal, so it appears on the X-ray as if it's extremely closed. This is a posterior flange covering the posterior aspect of the cup. The dual mobility cemented cup coming from other companies are flat cups with no long posterior wall.
All right. Excellent. How much shortening you had at the end of this surgery, clinically?
Now he has 2.5 centimeters.
2.5. Okay.
Yes.
Okay, that's actually an excellent result at the end. And do you have any other X-rays after that, or healing the osteotomy side or so?
Unfortunately, I didn't have the follow-up X-ray for the patient. Now he is in prison.
All right. Okay. All right. Okay. Thank you very much.
That's very good for you that you lost him.
Good for the last case.
He is an addict. Of course, he is doing well. Actually, he's doing well. I swear, he's doing well. He is coming out of jail.
Must be doing very well.
I will see this next year. Next thing, inshallah.
We will have 15 years follow-up X-ray.
Yeah. Right. Thank you very much, Dr. Ahmed.
Thank you, sir. Thank you, sir.
Thank you.
Well done, Ahmed. Thank you very much.
Thank you, Dr. Mahmoud. Thank you. Thank you.
Dr. Ahmed,
I think this makes up come to the end of this very successful webinar. I thank Abu again and Dr. Khairi Abu Ghali for his contribution and his financial support of our society. I thank all the speakers for their excellent presentation, and I thank all the attendees. Just before closure, I remind you that our next webinar will be on the 18th of December, and this will be about fracture of the neck of femur in young adults. I hope that all of you will attend this webinar. Thank you very much, all our colleagues.
Thank you very much.
Thank you very much.
Thank you.
Thank you very much to everyone. Thank you.
Thank you very much, Professor Yadar. Thank you.
Professor
Thank you very much, everybody.
Thank
you. I've kept you until so late. Thank you.
Thank you,
Thank you, Ayman. Thank you, everybody. Bye.